Good afternoon. My name is Maria Giovanna Trovato. I'm a molecular biologist with expertise in grant and pharmaceutical management. Over the past 10 years, I've had the privilege of working closely with several pharmaceutical companies, society and association, mostly in oncology and hematology. I currently work as global strategy and BD lead in health and life sciences at Northeastern University Institute for Experiential AI. Today, I have the pleasure to talk about sensing and AI in ethics application in health. We invited four experts who will introduce us to the topic and will later on walk us through some of the most interesting use cases. The Institute for Experiential AI aims to bring human-centric principle to the practice of artificial intelligence across industry and academia. The EAI develops real solutions to real problems by working with real data. This way, we create ad hoc AI solutions to engage with private organizations at different levels. Our offering spans between educational and research initiatives, not only in health and life science, but also insurance and finance, as well as climate sustainability. We've witnessed how AI has incredible potential to transform human health, but sensing technology will be critical to reaching that potential. Sensing is a very broad field that includes wearables and devices that varies from the most common fitness tracker to sleep tracking mats, motion sensor, and stroke prevention earbuds, and so much more. These technologies holds incredible promise to improve people's lives. However, in order to realize that promise, the people who create this technology needs to develop a full understanding of the risk associated with collecting sensitive data and using AI for product development and management. This way, responsible AI will become part of the platform for innovation in addition to guarding against risks. We've brought together four experts to discuss sensing technology and responsible AI today. First, allow me to introduce our first speaker, Dr. Eugene Tunik. Eugene is the Director of AI Plus Health at the Institute for Experiential AI and Associate Dean of the Research and Innovation on Northeastern's Bouvet College of Health Sciences. He directs the Laboratory for Movement Neuroscience, where research focuses on studying cognitive motor interaction in health and disease, as well as improving human-robot interaction. Approaches in the lab include virtual reality, non-invasive brain stimulation, physiological recording, and measurements of movements. Eugene, thank you for being with us today and for joining.
Thank you for having me, Maria Joanna. Pleasure to be here.
Let's begin this conversation with a simple definition. When we say wearables, what specifically are we talking about? And exactly what do sensors mean in this context?
Thanks for that question, Maria Giovanna. Great question. Wearable technology is sensing technology that is either attached to the body through adhesives or worn on the wrist or even embedded in clothing. And the sensing technology is designed to provide information about the wearer's state, whether it's physiological state, such as a heart rhythm, or a subjective report about something, or something about their movement. Wearable technology is sort of enabling this ubiquitous connectivity between the sensor and the individual who is wearing a behavioral state.
Thank you, Jean. And what role does artificial intelligence typically play in the development of wearables and other sensing devices for health?
AI is having an ever-increasing role in wearable technology. We have to remember that wearable technology is providing the data that will serve as input to the AI models. So the quality of the AI model's predictions really is entirely dependent on the quality of the input data that is provided by the wearable technology. Looking at it the other way, AI technology is also in the future going to be serving wearable technology development. For example, as AI algorithms, AI models are going to be embedded locally at the sensor level, it will enable smart data sampling in the ecological environment.
Thanks, Jean. This is the right moment to mention the experiential AI that at EAI we define as experiential AI is the human-centric AI approach with the human in the loop. I work with you every day on AI plus health area, and I know the type of question we usually receive around our approach, our technology, and what really are our core principles that defines the AI. But can you tell me a bit more about why this approach is so important for us?
Absolutely, Maria Giovanna, great question. We have to remember that the data coming from wearables are coming from humans. The AI algorithms that are receiving those data can't be developed in a vacuum without an understanding of what that data mean, what the capacity and limitations of the sensing technology are with respect to bias, and who the individuals are that the data is being collected on, and what the outcomes for those individuals might indicate. And so at each of the steps in this entire life cycle, we need a team of experts ranging from computer scientists, programmers, ethicists, subject matter experts, clinicians, and so on, to band together to work on a common problem that they're trying to solve with an AI-based solutions. This is our human-centric approach to AI.
That's wonderful. You actually brought up a very important point. And we need to keep in mind that there is also an ethics and performance component to it, that it's very important, and we'll hear all about from Cansu later on. But first, we'll hear directly from you. So without further ado, I'd like to introduce Eugene Tunik, Director of AI Plus Health at the Institute for Experiential AI, to lead this webinar titled Sensing and AI Ethics Applications in Health.
Thank you, Maria Giovanna. At Northeastern and at the Institute for Experiential AI, we have a rich program that falls under the AI Plus Health division that spans remote sensing for health and healthcare applications, wearables and IoT, uh, AI in diagnostic medicine, AI for drug discovery, delivery and development, and many other health and wellness and healthcare applications. We're going to touch on a few of those, but first, let me begin by painting kind of the larger ecosystem in the AI and sensing tech space. It's really remarkable, the growth in the wearable sensors space that has been kind of tracking in parallel with the growth in the market for artificial intelligence. The two are growing at exponential rates and almost in parallel with each other. And it's really no surprise that that's happening. The two, artificial intelligence and wearable sensing technologies, are so intertwined with each other, right? As I mentioned earlier, AI algorithms are highly dependent on the sensing technologies that are used to feed the data. At the same time, the sensing technologies are becoming more and more dependent on AI-enabled sampling and data compression. So the two are going to continue to grow together and become more and more intertwined. In today's healthcare model, really the big challenge is all about data. Currently, the data that's collected on individuals is extremely sparse. Really think about the number of times that you see your physician, maybe once or twice a year during a wellness visit, maybe once or twice when you're sick. Um, Sensing technology really is at a watershed time to transform that, right? We're able to now collect continuous monitoring, real world data about individuals, about all kinds of metrics in the individuals. And we're able to build models, and I'll mention what I mean by explainable AI models in a bit, to process and sift through that massive mountain of data. Uh, you know, Humans are not built to filter that massive amount of data on their own. This is where AI technology can really step in and save the day. At the end, really, the promise is that the combination of sensing technology and AI models, good AI models, can create a clinical decision support system that is much richer than what's currently available to the clinical staff. Currently, it's more akin to just very simple data visualization of EHRs. And really, the point I want to make here is that the real challenge is that the ability to take the continuous data streaming from sensing technologies and integrating it with existing electronic health records. Right now, the electronic health records are really pieces of information from your sporadic visits to the physician. What they have the potential to be is really an all-encompassing system about one's big picture of health. And really, that's the opportunity space that we're talking about. But there's a real challenge here, right? There's a real challenge that we have to create sensing technology and AI models that create a degree of trust between the data that they're collecting and the end users that are receiving the outputs of these models. Really, right now, so what we're looking for is this triangle of trust between the patient, clinician, and the AI models. Currently, what we have is more along the lines of the figure on the right, where the AI model will spit out some sort of output based on some sort of hidden latent signal from the data from the sensor, and we have no idea why it came to the conclusion that it came to. What I'm advocating for here, in order for AI and sensing technology to become useful for individuals, for clinical staff, and so forth, is that AI models move from what they are today, really non-explainable, where a model is trained on a ton of data sets, a ton of images, to use a radiology example, for instance, and then inform a clinician about the likelihood of a fracture or not in a given image, without the clinician really knowing why the AI model came to the output that it did, to a more explainable AI system where the model is really trained on a set of heuristics about why a fracture might be determined in a given image, right? Maybe there's a certain misalignment in the bones, maybe there's a contrast here or there, maybe it's taken into account something about the mechanism of injury from the electronic health record, and piecing that all together with a given set of heuristics, the clinician would really understand why the AI model came to the conclusion that it did. This sort of arrangement creates a nice trusted relationship, and it also provides an opportunity for the end user, such as a clinician, to provide feedback back to the model so that they can be trained and improved down the road. This is currently not the case in practice. This is actually where some of the research projects that you will hear later on at this webinar are heading into that direction. The end goal here is to, as we're getting more and more complicated data, multi-sensor data that requires sophisticated models, for example, such as deep learning models that have reasonably good performance, but we have absolutely no idea what's going on under the hood, to reinvent how these models are working so that they're more understandable and explainable to the end users. Really, the potential here is unprecedented. Okay, we can create a clinical care model where AI at its center can transform doctor-patient interactions that are averaging right now only about 13, 15 minutes per patient, to allow the physician to have automated, for example, note generation from clinician-patient interactions, so that most of the visit is not spent by the doctor dictating notes, which is currently the case. We can have automated ecological data sampling and labeling between patient and sensing technologies. That data, AI can be used to compress that data, label that data, and fuse that data with electronic healthcare records so that they become an aggregate of information. And finally, visualization platforms of the aggregated data can be largely improved by AI models, so that the physician really has a clear image of the big picture of a patient's status. So with that, I'll just overview a couple of the research programs that are going on at the university, certainly not all inclusive. In the space of, for example, virtual reality, serious gaming, and healthy aging, we have tons of research in that space of how to leverage AI applications to create intelligent VR systems and read in the data collected during those interactions. On various imaging modalities, automated segmentation and identification of pathology, multi-sensor data coming in from EEG, eye movements, taste, and other types of devices worn on the body to improve human-computer interactions. AI-enabled cyber remote physical therapy using robotics, AI to detect subtle signatures of developmental delay, and of course, AI-enabled sensing of critically ill individuals.
Thank you, Jean, for your presentation. It was extremely interesting. Our second speaker is Ray Winslow. Ray is the Director of Life Science and Medicine Research at the Roux Institute. He is a very well-known worldwide leader in computational medicine, an emerging discipline that applies mathematics, engineering, and computational science to understanding human diseases. He holds a PhD in biomedical engineering, and he is also a professor at Northeastern College of Engineering and holds appointments in the Corey College of Computer Science and the Bubé College of Health Sciences School of Clinical and Rehabilitational Science. Ray believes that medicine is increasingly become a computational discipline and that the algorithm is becoming a valuable member of the healthcare team. Big data can not only help drive decision and practice in medicine, but when paired with real-time health monitoring devices, it may help predict instances of stroke, septic shock, and heart attack. His research focuses on two specific areas. The first is use the computational modeling to understand the molecular mechanism of a cardiac arrhythmia or irregular heartbeats or sudden cardiac attack. The second is use of modeling methods to predict both the evolution of a patient's health status over time and predict the onset of adverse health outcomes before they happen. Today, he is going to talk about a really interesting use case, which is called the HEART Project, Healthcare Enabled by AI in Real Time.
Thank you for the introduction, Maria Giovanna. I appreciate the chance to be on the panel. So I've worked in sensing and AI applications in clinical care for about the last decade. I'm going to go through some core concepts and how we approach these problems, what we've learned from solving these kinds of problems, what kind of impact these solutions can have in healthcare. And in this first slide, I'm just summarizing some core elements about sensing that have already been presented. My work has tended to focus a great deal in the acute care setting, and in particular in the critical care setting. In this slide, in the left panel, you see an image of an infant. This is an infant in the pediatric ICU at Johns Hopkins Medicine. This is a very sick child, and the point of this image is to show that critical care patients are, of course, the sickest patients in the hospital. They're very heavily instrumented to measure everything relevant about their physiologic function and their state that we can measure. And so here's a list of quantities such as arterial blood oxygen saturation, the ECG, heart rate, blood pressures, respiratory rate, temperature, intracranial pressure, EEGs, laboratory results from these patients. They're all available in the acute care setting and certainly in the critical care setting. Then there's the other end of the spectrum, home care, or the home and daily life, where Gene and Maria Giovanna have already talked about the importance of wearable and nearable technologies, and that's certainly true when we work in this space. And then there's this really interesting notion that Gene raised to me before anybody else did, Eugene Tunik. And it's the continuum of care. And it's the idea that even within an acute care setting, there are things about patient activity, such as their motion, that is not typically measured in the acute care setting, but whose measurement can have great value in guiding care for that patient. And so Gene and my interests are in introducing wearables and nearables in the pre-hospitalization setting, while patients are hospitaled, when patients transition from acute care to physical rehab and occupational therapy in a care facility, and when they go home. And that's what Gene refers to as the use of sensing in the continuum of care, all of those different care settings, so we can track how a patient is doing regardless of where they are in the care environment that they're in, including into their home, with the ultimate goal of making it safer to quickly transition patients back into their home and everyday life, and be able to help them and monitor them more continuously and more precisely, even as they go about their everyday life. In this next slide, I'm talking about a particular project that Gene and I are working on together. It's called HEART, which stands for Healthcare Enabled by AI in Real Time. HEART is a prototypical example of how we approach these prediction problems and care problems in critical care and acute care. And the global overview of HEART is that, and of all these predictive problems that we're approaching, is that we're capturing data about patients. We're using those data to build predictive models of patients, and then we're harnessing the predictions of those models to suggest care recommendations to caregivers across the spectrum of caregivers on behalf of patients. This particular project is about collecting data from patients who are in cardiothoracic ICU intensive care units, and they're recovering from cardiothoracic surgeries. Roughly 80% of these patients do just fine. They never have complications. They recover, they go home, and their surgeries are a success. About 20% of these patients, however, do experience one or more complication, one or more adverse events when they're recovering from their surgeries in the cardiothoracic ICU. And about a quarter of those patients, so about 5% overall, don't survive these complications. And so the goal of HEART is to be able to reduce this number of patients who experience complications as they're recovering, and in particular, to reduce the number of patients who don't survive these complications. And the way HEART seeks to do that is by taking many different types of sensor data from patients continuously while they're in the cardiothoracic ICU, and using machine learning methods to construct risk scores for these patients. Now, since data are flowing in continuously over time, and those data include physiologic waveforms from patient monitors, minute-by-minute vital signs data, and variables out of the electronic health record, which at Maine Medical Center, where we work, is the EPIC electronic medical record. And that's things like lab results, medications being delivered, and so forth. These data are being captured over time. The risk of these patients for developing a complication is updated continuously over time. And we have developed a strategy for using that risk score to then reliably identify patients who are at risk for particular kinds of complications. And our goal is to feedback this information, and that information is patient X in bed Y is at risk for sepsis, for example. We want to give a reliability estimate of that prediction. Sometimes our predictions we estimate as being, using patient-specific data, by the way, as estimate as being 90% confident, or maybe sometimes we're only 30% confident. If a caregiver knows that confidence level, their reaction to that recommendation and the way they consider a treatment for that patient could be very, very different. So in any event, we are providing these kinds of information to caregivers, making recommendations about what we believe is going to happen to the patient. In our loop, the ultimate decider here is the caregiver. It may be the attending physician for this patient sees this new kind of information that we're feeding back to them, and they will weigh it with other information that they have and their own personal knowledge of their patient's condition, and make an ultimate decision on how to treat patients. So the next slide goes into a little more detail, and I'm continuing with this example of sepsis. And here the prediction problem is we are assuming that a patient may have sepsis. Maybe the complication they experienced in the CTICU is they developed sepsis. We're going to build a predictor to identify reliably those patients who will transition to a more serious state of sepsis known as septic shock. And the way we do this is to build a risk score using a machine learning method. This is a particularly simple machine learning method known as logistic regression. And an advantage of logistic regression is that it works fairly well. There are other methods, machine learning methods for building this risk that work better, and we use those. But logistic regression has this beautiful property of interpretability that Gene talked about. And what does that mean? Here are the most important features measured from these patients that are the most important drivers of these risk score. To me, interpretability means this learning method enables us to determine what is the most important measurement that typically drives the risk score. In patients with sepsis and septic shock, no surprise, it's blood lactate level. And here we rank order some of the other features that are very important in identifying this patient's risk. Here's an example. It's just a hypothetical example of a patient's risk score evolving in time. In this example, during this time interval shown here, the patient is in sepsis. And in this time interval here, the patient has now met the clinical criteria for being in septic shock. Our goal is to make advanced predictions about which patients are very likely to enter the state of septic shock, given that they're already in sepsis. And we want to do it as early as possible, which means that we want to drive this vertical bar back in time as far as we can, so we have as much advanced warning while this patient is still in sepsis, that they are going to transition to septic shock. And if we can do that reliably, then we can make accurate predictions about which patients are at risk for septic shock. And the way we do it is we find a threshold. We learn a threshold on this risk and ask the question, is there a threshold on this risk that yields acceptable and reliable performance in this prediction problem? The answer to this question is yes. And here's a summary of our findings from this sepsis study. It's really interesting, I think. What I'm showing you here are risk scores collated, assembled together from thousands and thousands of patients who have undergone a transition from sepsis to septic shock. And this was done using a data analytic method known as spectral clustering. What this analysis is showing us, so here is time on this axis, and time 0 is when each patient's risk score crossed the threshold that I just spoke of that says they're going into septic shock. So we aligned all their different risks for thousands and thousands of patients at time 0, and we looked at the properties of their risk score. There's a whole bunch of important things to say about these data. The first is that prior to threshold crossing, there's no difference between any patient. The differences emerge after threshold crossing. You see different categories of risk. Let's consider the patients with the highest risk that jumps up really quickly to a high value and stays high over time. The mortality rate in this population of patients is nearly 50%. I won't go into the details, but it turns out that these patients are undertreated for sepsis. They haven't been adequately given fluids. They haven't been adequately treated with vasopressors. This may explain the high mortality rate. Nearly 80% of them, in fact, do go into shock. So yes, of course, we make some mistakes in this prediction, but a high fraction of them, in fact, do go into shock. Another critically important aspect of this data set here is the sharp increase in risk that happens over a time frame of tens of minutes. These patients are in a completely different world of risk in this time period versus 20 minutes later in this time period. No human can make this determination continuously over the course of a week for a given patient. Only AI data-driven methodologies can watch these patients continuously and issue reliable alerts that something dramatic has happened to the state of this patient. The average early warning for these high-risk patients is 10 hours before they in fact transition to septic shock. That is adequate time for caregivers to intervene. We know from clinical studies that during that average 10-hour time period, when these patients today are going untreated, their risk of mortality doubles over that 10 hours because they aren't yet meeting the clinical criteria for septic shock. The clinical world doesn't consider them to be in septic shock. I consider them to be in septic shock. I think that's a result of this machine learning exercise, that the clinical criteria used for septic shock, I don't believe are right. I think this machine learning method is telling us it is at this time point, when their risk score crosses this threshold, that these patients are in a completely different world of risk and they in fact have septic shock. This is just a different example here in the case of pediatric multiple organ dysfunction syndrome, showing you an even more dramatic case of how risk scores behave over time, pre and post threshold. Here, the positive value of our predictions that a child will get multiple organ dysfunction syndrome we're 97% correct for these high-risk kids. And we can make these predictions 37 hours advance. So I think these technologies are going to be absolutely transformative in healthcare and in critical care. I like to summarize it by saying the algorithm we called will become a valued and ubiquitous member of the healthcare team. Thank you, Maria Giovanna.
Thank you, Ray. The algorithm will definitely become part of the healthcare team, and thank you for sharing the HEART project to showcase just one of the examples where sensing technology can really make a difference. Now I have the pleasure to introduce you Dr. Karen Quigley. She's a professor of psychology at Northeastern University and a member of the Institute for Experiential AI. Dr. Quigley directs the Interdisciplinary Effective Science Laboratory together with Dr. Lisa Feldman-Barrett, and within the College of Science, of course, in the Department of Psychology. Karen research broadly focused on how the body and brain together create experience and behavior. In her basic research, she examined the psychopsychological behavior and contextual features associated with instances of affective experience like emotions and stress. In her applied research, Karen assesses affective experience and health outcomes in those experiencing negative functional impacts after a major, for instance, live event like a military deployment or in a community member who experienced a terrorism event. Welcome, Karen.
Maria Giovanna, thank you so much for inviting me. I'm really excited to be part of this panel. What I wanted to talk a little bit about today is the promise of wearables for AI and health. And this is together with my collaborator, colleague, and co-director of our lab, Lisa Feldman-Barrett. So my goal today is to highlight just a few important issues that we need to consider when we're designing new wearables for AI and health and well-being. And I want to make 4 claims about responsible wearable design. So first of all, the data has to be high quality, reliable, and multimodal. And to a point that Jean made earlier, it also needs to be deeply sampled. So by multimodal, what I mean is reliable models are going to require multiple signals, very much like what Ray was showing. Those multiple signals are going to be necessary in order to produce reliable results that can guide health behavior change or other interventions. In addition, current evidence suggests that there is really wide variation across people. So predictive models really have to be created at the level of the person, not a group. And I won't have time today to talk at all about our theory and how it guides a person-specific approach, but I will show you a little bit of data that illustrates this approach and also just the incredible extensive amount of variation there are across people. Third, a user's data really has to be accessible and comprehensible to them, at least for them to be able to get that data. And fourth, and this is not going to require convincing any of you, but wearable data has to be secure and protect the user's privacy. So to illustrate the importance of these first 2 points, I just want to show a little bit about a new method that we've developed in my lab that ensures that we can measure subjective reports of experience, but we made a critical innovation. And here, the innovation is that we use a person's own biological signals to trigger an self-report, or what we would call an experience sample, of their current experience. Now, in medicine, what a patient says matters a whole lot. Healthcare providers ask people to report their bodily symptoms. Are you feeling pain? Do you have stomach discomfort? They might also ask you about mood. Are you feeling sad? Are you feeling... And people often seek out healthcare because of a change in the way they feel. And in psychology, we also very commonly ask people to report how they feel. And in fact, in the moment ratings of experience or experience samples, they're considered really the highest quality data because they are not influenced by retrospective reporting bias. And in psychology, we use experience sampling to measure in the moment experience in daily life. And in this study, we sent people out into their everyday lives while we measured their peripheral physiology. And each day, participants were outfitted with sensors and portable equipment to capture their electrocardiogram and also something called the impedance cardiogram, which gives us a little bit of extra hemodynamic data so we can understand more about the full cardiovascular picture. We also measure their movement and their posture. And these folks wore this gear for an admirable 8 hours a day for 14 days. And then what we do is we use the person's own biology to trigger a sampling moment. So to do that, we send a trigger every time we see a change, in this case, in the user's heart rate, that occurred for a few seconds, and it was larger than average relative to their baseline. And in addition, when they hadn't just moved or changed their posture, because that's going to cause a cardiovascular change as well. So here the idea is that if I haven't just moved and I didn't just stand up, and I have a relatively notable change in my heart rate, it's fairly likely that a psychological event has just happened. And so what this lets us do is to increase our likelihood of sampling a psychologically meaningful moment. It gets us ahead of and a little bit further than typical random sampling, which is very commonly done. Now, at each sampling moment, participants receive a prompt on a phone that asks them to report their current affective experience. So how pleasant or unpleasant are you feeling? Or how activated or deactivated do you feel? And then they were asked to list some emotion labels and provide intensity ratings. And what this procedure lets us do is we can inductively learn which patterns of physiological change correspond to which psychological features. We looked across all participants. We identified 219 different clusters of physiological features or patterns of physiological change. And interestingly enough, 44 of these patterns were broadly similar in at least 2 people. And these accounted for about 2/3 of the clusters. So what it means is that there's also 1/3 of patterns that were actually unique to one person. In addition, no single pattern was found in all participants. So what this really is evidence of quite substantial variation in these patterns across people. When we also looked at the number of patterns that are needed to describe these physiological changes across all sampling instances for each person, we saw that you could use 3 clusters to describe the physiological data for 8 of our participants. 4 clusters better described the physiological data for 12 people, 5 clusters for 14 participants, and so on. And so what this shows is that people varied in the number of physiological patterns that describe their data and in the nature of those patterns. So think about the data from these last 2 slides and think about what would happen if we had ignored this structure in the variation and simply aggregated all of this data, which as psychological scientists, we sometimes do. So AI researchers, psychologists, and I will say lay people often assume that specific physiological patterns are associated in a one-to-one way with each emotion category. However, that isn't what we saw. So here what we have are 2 panels showing the top 10 physiological patterns that we saw, most common ones. Those are listed on the horizontal axis. The red matrix is the pleasant emotion reports, and the ones on the right, the blue, are the unpleasant terms. And the bigger the dot in the matrix, the more subjects who reported that emotion label for a given pattern. And what you can see is that each pattern maps to many different emotion labels, and a given emotion label is associated with multiple physiological patterns. And this is what we would call a many-to-many mapping. It's really important to say this is not random, it's structured variation. And unfortunately, because this is a smallish study, it's a proof of concept study, and we don't have enough subjects really here to learn what exactly is structuring this variation. And I will just say that this was a pilot study, took about 2.5 years to run, and it took us about twice that long before we could get it funded because we had to convince people that this was an important thing to do. That's how strong the belief about a one-to-one mapping is in psychology. So why is this important? Well, one of the great unsolved problems in psychology is the lack of correspondence between subjective reports and physical measures in the body. And our hypothesis is that this lack of correspondence is because psychologists are not designing their studies to sample and model the variation sufficiently. And in fact, we developed this biologically triggered experience sampling method so that we could efficiently sample many, many moments of bodily change, their corresponding subjective reports. And I think that this particular method can actually be a game changer for a lot of questions in AI and health. As I mentioned earlier, self-reports are everywhere in medicine. They send people to the hospital, they send people to a doctor. Sometimes they're used to track intervention success in a treatment trial. And so these are the kinds of self-reports, and their use in medicine is just incredibly common. And AI companies often want to take physical measures from the body and infer a person's experience. And I think what these data show is that it's not really that simple. And this mapping can't be assumed to be the same across all people. I think Ray's data shows that beautifully as well. And this method, with some modifications to increase its scalability and wearability, really has a lot of promise, I think, for studying the factors that do structure this wide variation that we observe so that we can then create person-specific models. Returning to the remaining 2 points about responsible design, I want to tell you a little bit about a study that I did during my time at the VA. I do really think that it's important that users can access and understand their own wearable data as much as possible. And wearable companies can make this accessible. So in this project that I did with the Department of Veterans Affairs, we wanted to support better sleep hygiene using self-management for chronic insomnia. And as part of that study, we provided a sleep report to our veteran participants as part of a pilot randomized control trial. And we gave users several health information technology tools. You can see a couple of them here. One of them is an app that runs on a phone. It's called the CBTI Coach. CBT stands for Cognitive Behavioral Therapy, and CBTI, or Cognitive Behavioral Therapy for Insomnia, is a very well-respected and very common insomnia treatment. And it has been created in app form here for use on a phone. And then what we paired this with is a sleep measurement device, which can detect a little bit about sleep stages and sleep apnea using a variety of physiological measures. Sleep apnea just being the obstruction in the airway that can then cause awakenings or microarousals during sleep. And the company that developed this, EHMR Medical, provides a very nice patient-friendly sleep report showing like how long the patient slept on the night of testing and whether they think they might have sleep apnea given their scores. And one of the things they did is it really walks the patient through what they're seeing here and tells them a little bit about their own data. And then in follow-up qualitative work, we use semi-structured interviews at the end of the study where patients reported gaining really useful insights from these wearables. And I'll just show you a couple of quotes here. So this was from one person: gave myself that peace of mind knowing that I don't have sleep apnea. So it's nothing I should have a concern about being the numbers being so low, but I'm not even close to like maybe being dangerous. It's like, no, you're really healthy. And this one, it was reassuring that though I perceive my sleep as being abnormally short, the scientific data says I'm sleeping longer than I think. These quotes, I think, suggest that patients can really gain important insights from their own data, especially when they trust that the wearable device is giving them something that's reliable and valid. And finally, nobody's going to argue with the idea that data has to be secure to ensure user privacy. However, it's not always easy as it might appear. But I think it's really crucial for ensuring that users trust both the companies that produce these things and that their data is not going to be shared beyond where they'd like to share it. So in both of the studies that I showed here as examples, the physiological data being collected doesn't stream to the cloud. It actually is stored locally on the device. And this does require more work by the researcher or the healthcare provider, or better yet, by an AI-based tool. And this keeps the data more secure because the data stays with the user. So my goal today was just to highlight a few important issues to consider for the ethical design of wearables and how wearables and AI can really be paired for incredibly useful outcomes, whether we're trying to enhance health or even well-being. This is a very rapidly changing area, as both Gene and Ray have pointed out. And I think the ethical design aspects always have to be foremost when we're considering how to develop and test new wearables. And I'd just like to finish by thanking the prior and present members of my lab, which, as I mentioned, I direct with Dr. Lisa Feldman-Barrett. I also really want to thank the funders of our work, especially the Army Research Institute, because they funded this biologically triggered experience sampling work, and also the VA and the Boston Roybal Center, which funded the insomnia work. Thank you.
Thank you, Karen. It is indeed a very important field, great presentation, and a really interesting topic. We'll now turn to the incredibly important topic of AI ethics in the world of sensing and wearables. As we've discussed, responsible implementation of artificial intelligence requires technical expertise, domain expertise, and ethics expertise. Even if you have those, it is not always easy to make them work together in a way that can produce results in a business environment. One of the world-leading experts in applied AI ethics, Dr. Cansu Canca, to discuss exactly what it takes. Cansu joined the Institute for Experiential AI as an ethics lead and a research associate professor. She has a doctorate in philosophy, specializing in applied ethics. She's the founder of AI Ethics Lab, one of the first initiatives focused exclusively on advancing practitioners and conducting multidisciplinary research on the ethics of artificial intelligence. She's among the 30 influential women advancing AI in Boston and 100 brilliant women in AI ethics. Welcome, Cansu.
Thank you, Maria Joanna. So I want to take a step back again and sort of like situate ethics in the world of this new biomedical world where AI is a part of where we are. I come from bioethics, as Maria Joanna mentioned, so I'm trained in applied ethics. And the way that we have been discussing the ethical questions in biomedical ethics is very much focused on the clinician and the researcher about what is the right thing to do. And from the perspective of the hospital and healthcare system, in the sense that what is the right policy to implement. And for doing this, we are really looking at the aspects of biomedical ethics in the sense of medical ethics, population level bioethics, public health ethics, and research ethics. But what has been in the last, let's say, decade leading up to this moment, what has been increasingly the case is that, as it has been shown by the previous speakers, AI is becoming more and more a part of this whole cycle, engaging with the patient, engaging with the hospital system, healthcare system, and engaging with the clinician researcher system, being a part of their decision-making. But we have not asked the question about what is going on in the AI itself. Are there ethical questions within the AI system that we need to resolve, and what are the ethical questions that we need to figure out as we are using the AI systems. So the way that I would add it would be to add the ethical question and add AI ethics and technology ethics in some sense as a part of biomedical ethics. So this doesn't mean, of course, AI ethics is like a subcategory. It just means that AI ethics, when we talk about the use of AI technologies in health, we are not exclusively talking about AI ethics. We are talking about the relationship between all of these different ethics fields, so to speak. So when we say responsible AI, what are we really talking about? What we want to make sure is that throughout the whole cycle of innovation, we have some evaluation and judgment on ethics in each aspect of the innovation cycle and looking at specific parts of the innovation cycle. So in some sense, we can define the goal of the responsible AI to say that to develop and design ethical technologies. And here we can think of this as, we can further divide this into two and say, one thing is to develop AI for good. So most of these technologies that has been discussed, all of these technologies that has been discussed, is aiming to make the patients and the population healthier. So clearly we are going towards the AI for health as soon as we are working in the healthcare area, AI for good, sorry. And the other part of this is that, well, regardless of the goal of the AI system, what does it mean to have a good AI system? So there we go into the question, as we are developing these systems, what are the value judgments that we are incorporating into them, which I will talk about a little bit more shortly. The second part of it, so this is the content part, the product. We are focusing on the product. The second aspect of this is the process. As we are developing technologies, be it in sensing technology, be it other technologies in healthcare or in other fields, can we make sure that the process of development is ethical? So this again takes us all the way from the data collection level to experimentation and research aspects as well. And finally, in the implementation, how do we make sure that the AI system is used ethically by both the professional actors, such as the physicians or the healthcare system, the policymakers within the healthcare systems and all of those, but also by the regular user, the patient, or not necessarily the patient, somebody who wants to lead a healthy life so that they don't become a patient. So we can say that the responsible AI really takes us, covers the whole scope of any innovation. So we start, as I said, from the conception of the project, so from the research phase, all the way through the design, development, deployment, updating, and monitoring phases of an innovation cycle, including a lot of the healthcare providers are not necessarily developing these systems in-house. So the procurement is also subject to ethical analysis and judgment. As we look at these different stages, we are also looking at different aspects of the technology. So the data, what are the questions that the data raises that the algorithm is trained on, or the technology is collecting going forward? What are the questions that the model, the algorithm itself is raising? Ethical questions that the algorithm itself is raising. Something that is being often, I think, overlooked is the tool itself, the user interface of the tool. How do we communicate? How do we make sure that the communication between the AI and the human, whoever that human is, again, could be the healthcare professional or the patient, how does that communication happen in an intelligent manner? And the practice, so again, going to the human-computer interaction, how do we make sure that we have systems, incentives, risk structures in place that we do not push healthcare professionals to over-rely on an AI tool, for example, in the fear of finding themselves in a position where they have to explain why they did not follow the AI system's recommendation. So when it comes to the wearables and sensing technologies, I'm just going to make this like concrete by using a very well-known common example. So if you just think about smartwatches, for example, that collect bodily data, that track bodily data, we can think of a whole bunch of ethical issues that arises at all stages of it again, right? So here, this is not an exhaustive list. I just listed a couple of the ethical concerns that one should be paying attention to. And these are like, starting from privacy, transparency, to agency, all the way to equal outcome, accuracy, well-being, and contestability. So I'm going to go a little bit in detail of what are the types of question that arises. So when we think about a smartwatch, as I said, that is following the user's bodily functions, activities, the main question that comes up, of course, is like, what is the data that the system is trained on, and how does it receive that data? Is the privacy issue is a big question as we develop these systems. Were the data sets acquired in an ethical manner, and do we create models that use data sets that are ethically justifiable and sustainable? And going forward, of course, you have the second part. As the user is using this, they are sharing their data. So how do we make sure what kind of privacy protecting technologies or privacy enhancing technologies can we put in place within the technology to ensure user privacy going forward? Who is the data being shared with as the user engages with this technology? And also, a lot of the information that we have that is about us is not in isolation. So a lot of the information that we are sharing also includes information about our environment, about others in our environment. So what about their privacy? How do we judge the violations on their privacy, and how do we make sure that we respect the others around us, their privacy? All of these tie to each other. These are not like super separate categories, obviously. In terms of trust privacy, do the users, and here, I mean, again, the users such as the typical individual user or a patient or a physician, do they understand what does the system do? This goes back to Gene's point about explainability. Do we understand what the limitations of the system? How does the system come into, if the AI technology gives you a risk score or an outcome, a simple outcome, what does that mean? How did it reach to this outcome? Another thing is that, do we know when are we being traced and tracked? How do the different tools that are embedded in our environment communicate with each other? So this takes us a little bit towards the Internet of Things area. Do we know when we are being tracked, and do we have a choice about this? Another very important question revolves around the fairness question. So when we are in equal outcome here and accuracy, we can sort of like think of them somewhat in connection with each other. As I said, all of these have some overlap anyway. We have to make sure that the outcome of these AI systems are comparable in terms of their accuracy, in terms of their impact on individuals between different groups. So this has come up in the literature many times by different AI technologies. So risk scoring of risk scoring of different levels of sickness between population groups, or by sensing technologies that are not as accurate, that are not as precise on darker skin tones than lighter skin tones. So one thing is to ensure that we have comparable outcomes. The other thing is to disclose if there's any fluctuation. And in terms of accuracy, we have to understand, how are we willing to make an error? What kind of errors are we considering acceptable? Depends on how do we define harm, and how do we understand the impact of this on different individuals and groups. So we can move to the other ones on the right. Agency is a major question when we talk about we need to find ways of how do we best communicate what the AI system does to the end users so that we support collaborative decision making. How do we make sure that within healthcare, for example, we create systems where physicians can intelligently and comfortably disagree with the technologies that they are using, the decision aid tools that they are using, but also they don't simply neglect or ignore it, and make sure that they do take these useful systems into account. The impact of the technologies that we are incorporating, and in a holistic manner, what is their impact on our societal, individual, environmental well-being. So we, of course, understand that we often think of this in terms of individual patients or populations, but there's also the environmental aspect. What does it mean to have a lot of the AI systems incorporated, running in our current world? And also, given that we have been living in a world where we did not have that much data about us, we did not know that much about ourselves. Now, how do we cope with the idea that we now get to know a lot? And how do we act on this information? Do we know how to act, or is it just are we just pushing ourselves to an anxiety-filled environment where there's a lot of information, but we don't know how to juggle that? And the contestability aspect of this is that, of course, if something is not correct, if something is wrong, either according to the healthcare professional or according to the user himself, herself, is there an easy route to fix these mistakes? And there are always some ways of providing feedback. There are always some ways of like fixing a technology, but having some way is not the same as a seamless and efficient manner of incorporating feedback into the technology. So where do those categories that I just talked about came from? Well, what we did previously in AI Ethics Lab is we created this tool called the box. The box is basically, here you see 18 instrumental principles that connect to 3 core principles. So respect for human autonomy, individual autonomy, harm-benefit balance, so you can call it do no harm and do good principles, and justice are the core principles that we have. And we connect the instrumental principles to these core values in terms of their support for the core values. So core values basically means that what are we trying to achieve when we say that something needs to be ethical. But what we mean is really, we want systems to respect autonomy. We want systems to do more good than harm. We want systems to not create unfair conditions. We don't necessarily mean that transparency is our end goal or privacy is our end goal, but our interest in transparency and privacy is so that we can exercise our autonomy. And anyone who comes from healthcare, who has been working in healthcare, of course, knows these categories, core values, don't come out of nowhere. They are the traditional bioethics principles. And even though, so the box is an AI ethics tool, but it is based on the traditional bioethics principles. And why is that the case? Well, so the box is a part of a bigger project that we did in the AI Ethics Lab, where we looked at, from 2015 until 2021, we looked at all of those publications about guidelines on AI ethics principles that countries, companies, intergovernmental organizations have released. And they are still releasing more. We stopped tracking after 2021, basically. So in that time span, over 100 guidelines on AI ethics principles have been released. Every company sort of pushed their own set of principles. But when we looked at them and collected them, they really fall under these 4, or you can say 3, because do no harm and do good is sort of like a balancing, comes together as a balancing act in some sense. So they fall under these categories. And it is also not surprising that they fall under these categories, because these are the categories that come from moral and political philosophy. So they have a long, hundreds and even perhaps thousands of years of history in the making, where we can get to these main core values. The way that these principles became the pillar of biomedical ethics was in the 1970s with the Belmont report in relation to research ethics. And we also did another project where we looked at, well, how well does the Belmont report help us make decisions when it comes to AI research with human subjects? So we looked at the information that we have, and not just Belmont report itself, but all the documentation that is being used by IRBs, by research ethics committees in the field, and how guiding they are when it comes to AI research. So Belmont report, as I said, the biomedical ethics principles, respect for persons, beneficence, and justice is the main core values. And then they are operationalized in the form of informed consent, private information, protecting private information, risk and benefit assessment, and avoidance of discrimination and bias. But when we apply these principles, when we take the perspective of AI research with human subjects, they do not provide enough guidance for us to answer these important ethical questions. But I just wanted to point out that both, in some sense, existing biomedical ethics principles are extremely useful in providing the framework that we are operating within, but in some other sense, they do not take us all the way and answer all of our AI ethics questions. So to deal with these, we also created some training sessions. So if you go to City Training, we have a webinar, some modules on how to think about them, and the details of this, of the box and the principles, the core values and the instrumental principles. You can find it in my article, Operationalizing AI Principles and AI Ethics Lab's toolkit. So I think one thing that I want to sort of come back to and emphasize is, like, where do we see responsible AI as all of these things are developing in the world? Wearables and sensing technologies and IoTs are especially super interesting because they are becoming so much a part of our everyday lives. and they don't need to be contained in healthcare area. So the sensing technologies, the development of them, sensing technologies, IoTs, and development of them really also impact what kind of a society we are creating. So when we talk about responsible AI, it's often, here's the conversation about technology and here's the conversation about responsible AI. But that is almost like setting ourselves up for a failure where we are going to end up with a unjust and unethical society. Whereas what we need to really be thinking is how to make sure that responsible AI connects with every technology that we are developing, and especially technologies that are becoming embedded, that are so close to ourselves and in the way that we interact with the world. And how do we make sure that responsible AI concerns, AI ethics concerns, are considered from the beginning in a serious way, in ways that are perhaps even more integrated and structured than we have achieved even with biomedical ethics.
Thank you, Cansu. I would like to thank our speakers for their invaluable insights. It was a pleasure to have you here today to guide us through the challenges and exciting application in this rapidly evolving field. So as we have seen, we must acknowledge the urgency to transform our healthcare systems, prioritizing patients' well-being and clinician satisfaction. By leveraging AI to optimize clinical workflow, reducing administrative burden, and enhance accuracy, we can unlock the full potential of our healthcare professionals. The journey towards a completely new healthcare model requires continuous innovation, research, and collaboration. It necessitates the development of explainable AI algorithms that inspire trust, reliable and relevant labeling of data, and the integration of patients' reported outcomes with wearable technology. We must be mindful of the limitations, of course, and the biases that can arise within AI systems by fostering collaboration between sensor technology developers, AI algorithm designers, and healthcare professionals. And this way, we can really develop a new system of information processing that ensure the highest standard of care. Again, everything we develop is built around the principle of human in the loop, as you can see. So we really think that AI can improve every aspect of our lives and, of course, patients' health. But the human in the loop is an absolute must. And just to clarify, not every human in the loop, but an expert in the loop that can really provide meaningful feedback throughout the system, and why we develop this technology and work towards a better progress. In conclusion, I'd like to say that the conversation around responsible AI in wearables are very, very common these days. With a lot of knowledge available, doesn't necessarily come transparency. That's why at EAI, we pride ourselves of building every solution, every research project, and every educational initiative we have to address very specific and unique needs. And the keywords for our offering is flexibility. We do recognize the immense value of solving real problem with real solution, and we witness how powerful our solution improve every aspect of healthcare and life science. We have a number of different areas we're currently developing solution for, and we look forward to meet you and answer your question. Our offering, of course, doesn't stop on engaging private organizations to deliver an AI solution, but involve a more comprehensive approach, an educational component as well. So we do have co-op, for instance, through which we could include students in our project, as well as upskilling program, executive training program that we develop in collaboration with the business school, and so on. Some of you we already had the pleasure of meeting the most recent conferences, for instance, HIMSS in Chicago or in Boston. And thank you again for being here with me today. For those of you I haven't had the chance to meet, I encourage you to get in touch and get the chance to explore the Institute for Experiential AI offering, our growing pipeline in health and life science, and the responsible AI practice. So what's next? First of all, we received a very high number of questions during this webinar, actually, and we will answer them as soon as possible. In the meantime, I highly encourage you to register to any new updates and upcoming webinars, subscribe to our newsletter, and follow up on social media. And since we're at time here, I would like to thank you once again, our speakers, and I would like to thank you all for attending and being with me today. For those of you who were unable to attend the live session, but they did complete the registration process, they will receive a recording of this webinar. And for all of the questions that we received before and during this hour, we will address them as soon as possible. In the meantime, I highly recommend again to reach out to us to know more about responsible AI, to know about our offering in AI plus health. And until then, have a great day.